Hey guys, so coming to the next video of the week, staging of testicular cancer. This was, we have to learn this in three headings. That is the TNM staging. Natural stage is 1, 2, 3. Then risk groups. Starting with the T staging, it is divided into clinical or pathological. First we'll see the clinical staging, which is either TIS or T4. The rest of the T1, T2, T3 are based on pathological findings. Clinically, we cannot assess them. And even the TIS, we cannot assess clinically, but it is based on biopsy. Biopsy shows germ cell intraepithelial neoplasia. Then it is TIS. And T4 is invasion of scrotum and adjacent structures. And coming to the pathological staging, which is more important, here it is divided into T1, T2, T3, and T4. In T1, the tumor is limited to testis and ready testis with no lymphovascular invasion. If the tumor is limited to testis and ready testis with the presence of lymphovascular invasion, then it is T2. Here we can see this part. This is testis, and all the seminiferous tubules opens into the ready testis. Similarly, in T2, there is involvement of testis and ready testis with presence of lymphovascular invasion, then it is T2. T1 is further divided into 1A and 1B, which this classification is applicable only to pure seminomas based on the size less than 3 centimeters and more than 3 centimeters. In T2, the involvement of adjacent soft tissue hilar structures and epididymis also comes under T2. Here you can see this epididymis and the hilum. Involvement of this comes under T2. Next, coming to T3, once the tumor spreads to spermatic cord, then it becomes T3. So the T1 is involvement of testis and ready testis, T2 is involvement of epididymis, and T3 is involvement of spermatic cord with or without presence of lymphovascular invasion. T4 is involvement of scrotum with or without presence of lymphovascular invasion. Then moving on to the end staging, this can also be either clinical or pathological. There isn't much difference between the two. It is divided into N1, N2 and N3. Based on the size and number. Based on the size, if the lymph nodal mass is less than or equal to 2 centimeters, it is N1. If it is 2 to 5 centimeters, it is N2. Anything more than 5 centimeter mass is N3. Based on the number, if the number is less than or equal to 5 nodes, if it is more than 5 nodes, it is N2. And presence of extranodal extension also comes under N2. Coming to the end staging, it is divided into M1A and M1B. M1A is non-retroperitoneal lymph nodes, that is non-regional nodes or presence of pulmonary metastasis. As we know, the cannon-ball metastasis. M1B is non-pulmonary metastasis, that is brain or bone injury. Based on serum markers, they are divided into S1, S2 and S3. LDH, AFP, beta HCG. LDH is less than 1.5 times upper normal limit, 1.5 to 10 times the upper normal limit, and more than 10 times the upper normal limit. AFP less than 1000 nanograms per ml, which is a standard unit, 1000 to 10,000, more than 10,000. Beta HCG levels, milli international units per ml, and 5,000, 5,000 to 50,000, more than 50,000. Testicular cancer does not have stage 4. It is divided into stages 1, 2, and 3. And stage 1, it is further divided into 1A, 1B, and 1S. S stands for serum tumor markers. 1A is T1, 1B includes T2, T3, and T4. You can also remember as stage 1 only the presence of T, no N0 and M0. Presence of nodal metastasis comes under stage 2, and presence of distant mets comes under stage 3. Here the serum markers are raised but with no tumor and no nodal metastasis or no distant mets. Just the serum markers are raised. Coming to stage 2, it is divided into 2A, 2B, and 2C. Here, as I've discussed, it is the presence of nodal metastasis, and it is divided into, if it is N1 comes under stage 2A, N2 comes under stage 2B, and 3 comes under stage 2C. Here the serum markers are either normal or just mildly raised, S0 or S1. Stage 3 is divided into 3A, 3B, and 3C. Here M1A comes under stage 3A and M1B comes under stage 3C. And the serum markers are S1, S2, and S3. Now moving on to the IGCCCG risk stratification. This is International Germ Cell Cancer Collaboration Group. They have divided advanced germ cell tumors into 3 risk groups. That is good prognosis, intermediate prognosis, and poor prognosis. It is different for seminomas and non-seminomas. In non-seminomatous tumors, the good prognostic factors are if the origin of the tumor is testicular or retroperitoneal tumors with only pulmonary metastasis and no other distant mets, and the tumor markers are within the range of only S1 or less. In intermediate prognosis, again the origin is either testicular or retroperitoneal with only pulmonary mets with no other distant non-pulmonary metastasis with tumor markers in the range of S2. In poor prognosis comes the mediastinal primary with non-pulmonary visceral metastasis like either bone mets or any non-regional nodal metastasis, and tumor markers in the range of S3 come under poor prognosis. Next, moving on to seminomas. There is no poor risk group. Seminomas carry a good prognosis and they have only good and intermediate risk groups. They could be of any site with only lung metastasis with any range of tumor markers. Coming to intermediate group, anything beyond lung metastasis, that is non-pulmonary visceral metastasis like bone or liver, come under intermediate risk group with any range of S. This is regarding important classifications in testicular cancers.